Translational research is very important. So you look for the defect and you try to treat it based on facts. That works well for medicine and oncology. However, it didn't work for surgery. It's the other way around. Most of the surgical achievements we have, we do it, based on experience or whatever, and then try to find the reasons why it works. Approach is not very good, especially for outcomes, and along 100 years dealing with, say, stress urinary incontinence in females, probably over 100 surgical procedures have been offered. And going back to DENERA is the reverse. I tried to take the concept of finding out what's wrong first before we treat. So observation-wise, when I was working with Ed McGuire and then back at Tulane, it was called urgency frequency syndrome, which is overactive bladder that is resistant to sometimes a refractory condition that medication is not effective or the side effects are more. So we started to do like abbreviated bladder denervation, doing a transvaginal approach, doing an inverted U and trying to burn the nerves in this area. We never see them, kind of intuitive, and we do that. And the results were decent, 60–70% success rate. However, the longevity or the outcome goes out by time. So it was, I tried to be more selective. So I did what's called subtrigonal Marcaine test to inject freezing material under the trigone and see if patients improve temporarily for a day or so, then they can go to surgery. However, it's not logical to go back in and do the surgery again and again, especially in a young woman. So that kind of abandoned at that point. Coming back to UCI here, I started to look into it again in the past 8–9 years. One of the things I worked with Dr. Landman, actually, we're trying to find a model. So we have a female pig and we tried radio frequency at different temperature. And at least, that study was published in the Gold Journal. And at least we found the effect on the nerve, but at higher temperature, there was also effects, or if you want to call it collateral damage to the technique. And it was done transurethral. At that point, it came to me the idea of why don't we do a transvaginal approach and refine the whole thing. And I did have a patent on the transvaginal approach for doing this. Then we studied the anatomy, and probably we were the first people really to redefine the anatomy in 3D to the lower urinary tract, and it was published in Journal of Urology in 2016–17. So we find the condensation of the autonomic nerve is under the trigone and probably proximal urethra too. But it was done on cadaver at that point, human cadavers. Then I took the idea and with the help of UCI Innovations, I was awarded a grant and bioengineering department at UCI as well. So we worked all together and developed a better model after searching the literature. So it with the female sheep that was very close anatomy to the human and very suitable for female pelvic reconstructive and other experiments in that area. So after bench work, just trying to define the anatomy, the feasibility, the fine-tuning the program to work with radio frequency, we developed a probe and animal model, and that was the base of the study that really published early this year on DENERA. And that's where the DENERA is the truther nerve radiofrequency ablation, kind of abbreviation to that. So indeed, in our study, in summary, we found that gentle radiofrequency, meaning temperature is low, can indeed cause nerve changes without doing collateral damage. And that was the major thing we have reached into that situation. So we had these animals, we tested them from the beginning as controls, and then 4 weeks and 1 month and 3 months. And at 3 months, we start to see some regeneration of the autonomic nerve. We used the special stains like S100, and that was published in Urology and Urodynamics. So after that, this is a story in general. After that, with the second logical step about humans. Having a procedure to be done in the clinic was just, local anesthetic, and almost no pain, is like a dream. So, if a lady comes in the office, have the procedure in less than half an hour and go drive her car and go home and have good results, then that would be really the success that we're looking for. So no anesthesia, not going to the OR, or even post-procedure problems like dysuria and hematuria and all that stuff, because we don't go through the urethra. At the same time, Chinese group have published on transurethral approach with radiofrequency, and that was good results too. So in general, I think radiofrequency, controlled radiofrequency, is a new innovation, just getting into the overactive bladder field. And I think, having success with that on humans will make it very, very valuable armamentarium for the practicing urologist that can be done in the clinic without much training or anything like that.